go into the health and psychosocial outcomes of long-term use. So this is when I'm talking about a woman that's pregnant, that's using cannabis for non-medical purposes, smoking it, and what could be the effect on the fetus, an unborn child. I think in South Africa we're very familiar with the concept of fetal alcohol spectrum disorders. We're actually the highest prevalence of fetal alcohol spectrum disorders in the world. Cannabis research regarding the impact on the fetus is relatively new again. Children exposed to cannabis may have higher rates of neurobehavioral and cognitive impairments. Children exposed to cannabis in utero demonstrate impaired attention, learning, memory, impulsivity, and behavioral problems, and may be at higher risk of using cannabis when they mature. What's also important is that there are challenges with doing these kind of studies, obviously for ethical purposes, but often women that are using cannabis in pregnancy are also using tobacco, and they're also using alcohol. So there are challenges in trying to decipher the exact impact of the cannabis. However, this data is taken from women that were using cannabis only. Effects may not become apparent until later in development, and therefore exposed children should be followed up late into adolescence. And I think that's where it differs from things like tobacco use in pregnancy and alcohol, that often you can pick up deficits in children at much younger ages. However, with cannabis, they're finding that the deficits may only be picked up late into adolescence. So I said I was going to talk to you about cannabis use disorder. And this is, in South Africa, the psychiatrists use what we call the DSM or the DSM-5. It's a statistical manual that we use in order to diagnose illnesses. However, there may be many different classifications. There's also the ICD, and within different countries, slightly different terms may be used to classify somebody as moving from just non-harmful use of a substance to one that becomes more harmful and begins to impact on one's day-to-day functioning and ability to fulfill roles. So a substance use disorder, and this is criteria that's used in the DSM across many different substances, but basically describes a problematic pattern of substance use that results in impairment in daily life or distress. And some of the criteria, so you need to have at least 2 or more of these criteria in a 12-month period, would be things like taking a substance in larger amounts over longer periods of time, spending more time using the substance, recovering from it or obtaining it, failure to fulfill major obligations and give up leisure activities, craving or strong desire to use a substance, recurrent use of substances despite harms that may have been associated with it, tolerance and dependence, basically tolerance referring to not being able to use the same amount of substance, needing more and more in order to achieve the same effect, and dependence referring to the impact of withdrawal symptoms and the need to use more of the substance to negate those withdrawal symptoms. Previously, it was thought that there was no such thing as a cannabis withdrawal. However, research has found, and classification systems now include cannabis withdrawal as a specific diagnosis. It's not exactly the same as you might have seen in the media of heroin withdrawal, for example, where people have cold turkey and very obvious physical symptoms. The cannabis withdrawal that I tend to see may be headaches, irritability, vague symptoms that are not easily or obviously being able to put down into figures like some of the other withdrawals. So many cannabis users or people that are proponents of the substance say that there is no such thing as becoming dependent on it. And unfortunately, from working in the field as well as researching in the field, I have noticed that actually there is a chance that you can become dependent on it. Dependency referring to the features that I've just mentioned. And what is the risk of somebody becoming dependent on something like cannabis? So studies have shown that about 16% of those who initiated cannabis in adolescence did become dependent or at risk of becoming dependent, that the risk of dependence is 33 to 50% in daily cannabis users, and that the harmful use of cannabis and cannabis dependence are the most common forms of drug use disorders in epidemiological surveys, mainly in first world or developed countries. It has also been found that approximately 13 million people claim to be cannabis dependent globally. Another perspective that I'd like you to think about when making a diagnosis of cannabis dependence. So often when you go to a doctor, you tell them something, they give you maybe do a battery of tests and they come up with a diagnosis. In the psychiatric field, it's a similar process in terms of we take a history, we do a physical examination or mental status examination. However, the tests that we have are not, I can't do a blood pressure to necessarily tell you that you have high blood pressure or do a glucose test to tell you that you are diabetic. So in order to make these kind of diagnoses of dependence, it's largely dependent on what somebody is self-reporting. And in that sense, what I'm trying to put forward is that it's not actually that psychiatrists or mental health care workers, psychologists or social workers are imposing a diagnosis that doesn't exist, but it's often from the evidence that you're getting from the person sitting in front of you that's saying, actually, this is quite harmful in my life. Actually, I am spending too much money on this or too much time on this, and I shouldn't, I should be doing other things with my time. Cannabis use and cognitive functioning. And here I come back to the term cognitive functioning and want to highlight the impact on adolescents again and why we keep stressing the risks of adolescent cannabis use. So what we do find is that early and persistent cannabis users showed an average decline of 8 IQ points compared with peers who had not used cannabis. And in this particular study that was done, what they actually did was take a few thousand cannabis users, it was 1,037. So they took children at the age of 13 and did tests on them, and this is prior to any onset of substance use, and then tested that exact same cohort at the age of 38 to try and see what would the impact of regular cannabis use be, and this is some of the findings. These findings have been replicated in other studies, like in the US. And the specific areas where impairment can occur is things like attention, learning, memory, inability to switch between ideas or responses. What we also find is that even with sustained abstinence, cognitive function recovery may not fully occur if it was initiated during adolescence. And something that I will repeat is that most of the risks we find associated with cannabis use is in those that initiate it at a younger age and those that use it at much higher dosages. To concur with the findings of what we would call testing, like neuropsychological testing, there are also studies that have done imaging, which means things like CT scans, MRIs, or SPECT studies, which try to understand if you take a control group of non-users and a group of users, what are the differences in the actual overall brain structure. Findings are not always consistent, but some of the main ones would be that there tends to be a decrease in the gray matter volume in specific areas, specifically in the hippocampal area and the amygdala of cannabis users. Cannabis use and psychosis. And as a psychiatrist, this is something that is very important to us. Before I go further, perhaps I need to speak about what is psychosis, what is schizophrenia. So the presence of psychotic symptoms or positive symptoms of psychosis may be things like delusions, hallucinations, so disorders in terms of your thought content and the thought form. Schizophrenia is not got anything to do with multiple personality disorders. It's a psychotic illness whereby a person has what we call positive symptoms, behavioral symptoms. The positive symptoms of schizophrenia is in terms of things like delusions and hallucinations, whereas the negative symptoms may be things like apathy, decrease in social interaction, communication with others, blunted affect. And it is a cluster of these symptoms that occur over long periods of time that one would make a diagnosis of schizophrenia. In the world of psychiatry, schizophrenia is a devastating illness because we have not actually gotten to a point where we can achieve results or recovery in schizophrenia like we might be able to do with other medical illness. It presents quite early in adolescence, in late adolescence, early adulthood, and it's not something that somebody necessarily gets cured by, but is on chronic treatment likely for the rest of their lives. So what do we know about cannabis and psychosis as well as cannabis and schizophrenia? So the use of cannabis before the age of 18 years is associated with an increased risk of psychosis compared to the association with initiation in adulthood. And this was repeated in many studies. The one big study is the 15-year follow-up study of over 50,000 Swedish conscripts. They found that those who used cannabis before the age of 15 had a 2.4 more likely risk to be diagnosed with schizophrenia. And these findings have been replicated in the Netherlands, Germany, and New Zealand. The onset of psychosis occurred earlier in those with early initiation of cannabis, so as early as 14 years or younger. And the early onset of psychosis is associated with poorer course and outcome. And this is by a review done from a South African psychiatrist. To stress a little bit further why we're so concerned about cannabis and psychosis, it's because the data, and there was a time where I do believe this was controversial, and there were people that really were not sure, can you make any associations? I think these days it is not as controversial, that there's mostly a general consensus that there is a link between the two, and those that don't really believe in the link between the two tend to be much fewer. So why are we so convinced? So just to stress, the association between exposure and outcome is there. So systematic reviews of prospective studies have produced pooled odds ratios varying between 1.4 and 2.3. That meaning the odds of developing the psychosis was 2.3 times more than somebody who did not use cannabis. Then we found that there's a temporal priority and a specificity. So the Dunedin study, which was done in New Zealand, found that early cannabis use between 15 years produced a 3-fold increased risk of schizophrenia, and other drugs did not produce these outcomes, therefore showing some specificity for the role of cannabis in this illness. And then in terms of the strength of the relationship, we do see that there's a dose-response relationship. And the Dutch Nemesis study was the one that basically showed us that the more of the substance that was used, the higher the risk or the outcome of schizophrenia or psychosis. What about cannabis and other mental illnesses? So what we do know is that there is a high comorbidity between cannabis use and anxiety disorders, depressive disorders, conduct disorders, and even eating disorders. However, longitudinal studies have not been able to demonstrate a causal relationship. So even though, as I said before, that when you look at a group of people with cannabis use disorders, they may have this comorbidity, it's not clear that there definitely is a causal relationship between those illnesses. Suicide, once again, there's mixed results when controlling for the confounders. So in adolescence, the earlier the intense use of cannabis, the greater the frequency or the vulnerability to develop suicidal ideation. And this doesn't necessarily mean somebody that attempted suicide, but an adolescent that was thinking about suicide. And in general, 9.5% of all toxicology reports for deaths by suicide show the presence of cannabis. So these are not studies done in developing countries, they mainly be done in the developed world. The gateway hypothesis, another very controversial one that many people, many people don't believe is true. What is the gateway hypothesis? The gateway hypothesis says that the use of softer drugs such as alcohol, tobacco, cannabis may lead to increased risk of more hard drugs or illicit substances like heroin or cocaine later in life. There are numerous studies that try to examine and understand what is the relationship between adolescent cannabis use and thereafter, use of other substances. And here are some of the findings. So studies in Australia, New Zealand, and the US found that regular cannabis users were more likely to use heroin and cocaine, and that the younger they were when they first used cannabis, the more likely they were to use other drugs. And how do we explain this kind of phenomenon? Is it just that it's the cannabis causing that? No, obviously there are other plausible explanations. One of them could be that an adolescent that uses something like cannabis just has the opportunity, because of where they're going to buy their substance from, the community that they're in, or the lifestyle that they're leading, to then buy what we call more illicit drugs. It could also be that early cannabis users were more likely to use illicit drugs for reasons that are completely unrelated to cannabis use. Or it could be that the pharmacological effects of the cannabis increased a young person's interest in using other illicit drugs. In terms of animal model studies, what they did find was that adult rats pre-treated with THC during adolescence and then allowed to mature to adult rats without THC are more likely to use heroin than rats not exposed to cannabis in adolescence. Just saying. And I suppose this is something of particular interest to me because of my study, and I'm not here to present the results of my study. This is a picture of Nyaupe users in Vereniging, and this is where I find, so I recruit Nyaupe users that enter rehabilitation, and then I follow them up 3 months after and then 9 months after rehab. And in order to find my participants, these are the kind of spots that I have to go to find them. It's a very sad reality of what's happening in terms of Nyaupe use, or I'd like to say heroin use in South Africa. And just to highlight just one main in terms of the gateway hypothesis and what my personal views could be about this. So I recruited 300 Nyaupe users entering inpatient rehabilitation. The median age of these users was 27 years of age. The median age at first substance use was 14 years. And 94.7 used cannabis regularly prior to onset of Nyaupe use. There were also extremely high uses of regular alcohol and cigarette prior to onset of Nyaupe use. So if you're familiar with epidemiological or clinical studies, you will quickly say to me, well, you can't make that association. You can't say that because they used cannabis before Nyaupe, that cannabis is the gateway, because I'm only looking at a sample of Nyaupe users. The ideal way to study this would be to look at a general population of adolescents and therefore follow them up over time, and then try and understand within that general population how many went over to proceed to include Nyaupe use. I strongly believe if we had to do a study like that within certain pockets or certain population groups within South Africa, we are likely to find that cannabis use does then lead to progressive use of more harder substances like heroin. And this brings me to what I'd like to talk about in terms of understanding risk in psychiatry. People in the mental health field have the difficulty of trying to explain very abstract concepts and risk. If I had to show you a picture of this person, or actually even if you didn't see a picture of this person, and I told you they weigh 130 kgs, has a cholesterol that's extremely high of 9, has a very high blood pressure and is diabetic, you can see from the picture is on an oxygen mask. And then I said to you, well, you know, do you think that we should feed him a diet of junk food, of chocolates and chips and burgers, fast food takeouts? I think your immediate response would be, that's a bad idea. Because we are quite familiar with certain illnesses, we're quite familiar with certain physiological findings or medical findings, and when talking to public, policymakers, whoever it is, something about this seems quite obvious, you know, like, duh, there's no other way to think about it. But if I show you a picture of this boy, and I try to convey to you a very similar message, it's not as easy for me to quantify, because these are topics, these are issues that are not easily measurable. However, they are not less important than the measurable ones. So what is the risk for cannabis initiation? Extreme poverty, and these are all based on research findings globally. School failure, low parental involvement, parental sibling modeling of drug use, mental health factors. We need to be mindful that use of cannabis in a person in poverty, an adolescent boy like the one that you see in this picture, is very different to that of an adolescent in a private school environment that has multiple protective factors, that this does not become a negative health impact. Statistics say that about 50% of our population live in poverty. And the risks in this individual of using cannabis is very different from the risks of somebody else. And I think if there's anything that I want to try and convey today, it's this very message. So the risk for cannabis dependence, so we spoke about just the initiation of cannabis, so low socioeconomic status, difficult financial situations, mental health factors, depression and anxiety in our youth populations are incredibly high. The kind of people that initiate cannabis use and end up on the streets, like the picture that I showed you before this, is likely not you or me sitting here at Empress Paris. But this is also not a fair representation of what is happening as a public health issue in South Africa. To long-term cannabis use and non-communicable diseases. And I think this is particularly important because the global burden of disease studies show that, especially in the developed world, there's a shift between the burden of disease being from infectious illnesses to non-communicable ones. So respiratory diseases, chronic bronchitis being one of them. What did the research show? That cannabis-only smokers were more likely to have reported cough, sputum, and wheezing, but not more likely to report shortness of breath than controls who did not smoke cannabis. So chronic obstructive pulmonary disease, COPD, is also one of those illnesses that we're trying to understand. And research in terms of the impact of cannabis on COPD is not completely clear as yet. However, something like chronic bronchitis, there is some evidence to show that there may be causality. Cardiovascular diseases, so there's a limited number of studies looking at this, but what we do know that there are CB1 and CB2 receptors in the heart. That increase in heart rate with acute intoxication is very common. The tolerance for that increase in heart rate does develop within about 2 to 4 weeks of ongoing cannabis use. That there's an increased occurrence of angina in people with pre-existing heart conditions, and that there are more recent case reports of increased cardiovascular disease in younger cannabis smokers. What about stroke? In the past decade, stroke in young adults has increased, and as a clinician working in a South African environment, especially with the high rate of HIV, I must say we have seen a numerous number of 20, 30-year-olds having stroke. The reason for this in South Africa might be different and not necessarily related to cannabis. However, we need to be mindful of what some of the data is showing in other countries. It was found that by 2015, there were about 100 cases of cannabis-related ischemic stroke that were reported, and that these cases of cannabis-related stroke are definitely on the increase if you compare it to data done in earlier samples. In terms of cancer, so we've heard about the effect of cannabis can have in terms of maybe assisting with cancer. Upper respiratory tract cancers, there's insufficient evidence to show that there's any causal relationship. Also because many of the people that present with these cancers are also using other substances. It's difficult to look at what is causing what. However, with testicular cancer in particular, there have been 3 US studies that found a relationship between cannabis smoking and testicular cancer. There were no potential confounding by tobacco, as tobacco has not been found to be a risk for testicular cancer. And it is plausible in the sense that there are cannabinoid receptors in the testes. So I can go to my conclusions because I think all of you have been listening for a very long time now. I think that cannabinoids are a diverse chemical compound that exert a range of effects. I think that from the first speaker to me, you can see that within this plant, there's many complexities. I think that there are significant health and social harms associated with cannabis use, and that the early onset and higher quantities of cannabis use are most strongly associated with these negative outcomes. My recommendations, I think that scientists, NGOs, policymakers, and the media need to be mindful of the language used when conveying information about cannabis. And what do I mean by this? I mean that there are various terms that we use when talking about cannabis and policy. And what gets conveyed to the public may not be actually factually correct. There is a difference between the cannabis plant, between novel psychoactive substances, between medicinal uses of cannabis. There are different cannabinoids, and each of these cannabinoids can have various different types of effects. There's a difference between decriminalization and legalization. We need to be so mindful of how we use these terms, because there are definitely long-term and significant impacts that these can have, particularly on youth. The idea that, recreational use, to use that term, or cannabis use disorders or cannabis dependence in youth is no longer an issue is actually not true. The US, for example, in these last few years, are doing major research into cannabis use in adolescents, because it's the one drug that continues to increase use in adolescents. So whereas things like tobacco and heroin use in adolescent groups are coming down, cannabis use tends to increase. And one of the major factors they're finding as to why the increase is happening is because of the youth's perception of the substance. And this is why I think, especially to the media that's out there, it's so important to really think about the terms and the phrases that we're using, because in 20, 30, 50 years down the line, we don't want to look back and say, we created this situation and actually we can't take those words back anymore. I do believe another recommendation is that more South African research and longitudinal studies are required in a range of fields. I've only just highlighted things like adolescent prospective studies of adolescent population groups, monitoring of road traffic accidents, maternal cannabis use, cannabis and non-communicable diseases. We also really need to look at culturally appropriate interventions in terms of primary through to tertiary intervention in South African setting. And lastly, I was trying to avoid getting into policy discussions, and I want to say that these are my personal views that I'll be expressing, and not necessarily views of any organization that I'm associated with. But I do believe that decisions regarding policy must take into account the views of all stakeholders. And what do I mean by this? If we look at the recent life Esidimeni situation that many of us in mental health are still trying to grapple or come to terms with, and I'm not saying this is the same thing with cannabis policy by any means, but if we try and analyze what happened there, we see that decisions were made, and there are many stakeholders involved in making these kind of policy decisions, each with their own reason for wanting to make the decision. People have economic vested interests in making a particular reason. They might have political reasons for making a particular reason. There might be personal reasons, pressures from all kinds of places. And what I do believe happened in the life Esidimeni is that the voice of the vulnerable people were not heard when that decision was made. The voice of the family members were not heard. And this is what I mean when it comes to big decisions and big policy decisions regarding something as complex as cannabis. Each person's voice needs to have an equal hearing space in these discussions. That it is not about one sector in terms of the economic benefits of this overpowering the voice of actually there's a lot of evidence to show something to the contrary. And so I'd like to leave you with that and take any questions from the audience.